Welcome, Faith. Thanks for joining. To kind of recap for anyone who is watching the video of this later, we're talking today about the PCARN rule. So this is a new clinical decision rule for the cervical spine. This is not the PCARN head injury rule, and we'll talk about that at another session down the road. We've gone through a couple cases so far. So to catch you up, Faith, and to catch up anybody who is watching the video later, we went through a patient who was severely injured, is 3 years old. She's unconscious and can't provide any, history. She can't tell us if she's in pain or not. And for that patient, we all kind of agreed that she's already going to the scanner to get a CT scan of her head. And so she's probably going to need a CT scan of the cervical spine based on our gestalt, meaning our gut instincts. But we went through the PCARN rule to see whether she would, in fact, meet criteria to get a CT scan of the neck. And based on that, she's totally altered. She's unresponsive. She's actually got normal airway breathing and circulation, but no focal deficits. And so the PCARN rule, if the risk of a cervical spine injury is more than 10%, then it recommends we get a CT scan of the C-spine. For case two, this is the one that's a little bit practice changing for lots of us. So this is a patient who had a diving injury and has a normal neurologic exam other than they are somewhat altered. So their GCS is 9. And then we went through the PCARN rule for this patient, and their GCS, like we said, is low, but they can respond to painful stimuli. They've got normal ABCs and no focal deficits. And so their risk of a cervical spine injury is about 2.8% based on the PCARN rule. And so those are people that we can actually order an x-ray for. And Dr. Nick and I were discussing that before this rule came out, we probably would have just gotten a CT scan of the neck if we're already getting a CT scan of the head. But that is not a benign study. It does carry a significant cancer risk for kids. So then our third case here, we've got a patient who fell down the stairs and hit her head. She had no neck symptoms that she was complaining about, a normal neurologic exam, and she's wide awake and can talk to us. And so for that group with the perfect GCS, the normal Glasgow Coma scale, the PCARN rule opens up 3 additional questions for us. And so those 3 additional questions you can see here are other signs of altered mental status, self-reported neck pain or tenderness, and then do they have severe injuries to other parts of the body like the head or the cervical, the head or the torso. And so for our patient, the answer is no for all 3 of those questions. And this agrees with the gut instinct that Dr. Nick and Deb and I all had, that this patient does not actually need any imaging. She can be clinically cleared from the perspective of the PCARN rule. Again, we're only going through the cervical spine rule today. We'll talk about the head injury rule maybe next month. But so let's say that the answer was yes to one of these questions. I wanted you guys to see the difference. So if you click yes for any of these 3 additional questions for the wide awake person with a GCS of 15, then you notice that the risk of a C-spine injury goes from that 0.2 up to 2.8. And then they fall into the you should probably get an x-ray category. So let's move on to actually a background on cervical spine injuries now that we've gone through these cases. So about 8 million kids in the US are evaluated for cervical spine injuries per year, which is a lot of people. I couldn't find any international data. I think it's going to differ by country for sure, depending on what kind of trauma that you have. I'm guessing in Uganda, where we've got a lot of trauma from motor vehicle accidents and bodas, the number might even be higher relative to the population. But out of the 8 million kids in our country who get evaluated for cervical spine injuries, only 1% of them have true C-spine injuries. So kids are pretty darn resilient. This is not something that happens very often. Kids who undergo CT imaging have a 24% higher risk of cancer within the first decade. So within the first 10 years after a CT, and just one cervical spine CT as a kid increases the lifetime risk of thyroid cancer by almost 80%. So I didn't realize that it was this high risk. It's pretty concerning. Upper cervical spine injuries are more common in very little kids. And then spinal cord injury without radiographic abnormality, or SCORA, is something we need to be aware of. And it's more common in younger children. I've only had maybe one SCORA patient ever. This is not something very common. If you've seen this before, I would love for you to chime in the chat. But it basically means that you get X-ray, CT, MRI, what have you, and it looks totally normal, but someone has focal neurologic deficits that suggest a spinal cord injury. So pretty uncommon, but it does happen in kids. So let's go over pathophysiology here. I think everyone knows that we've got C1 to 7. That's what we call the cervical spine. The top two vertebrae, the C1 and the C2, the atlas and the axis, are the two that are really scary if they get broken, and sometimes will often require surgical fixation if they get broken, because obviously they hold your head up. So if they break, your head kind of falls off and injures your cervical spine. And there are both stable and unstable cervical spine fractures. We won't get deep into those today, but just realize something is unstable if it compromises the safety of the cervical spinal cord, right? So we've got C1 through 7. The axis is C2, and you can see it has that little spike that goes up. That's also called the dens. There are 3 types of dens fractures that you can get. So some of them are just like put you in a halo, so put you in a fixation device for a long time. But if we get closer to the base here, that makes it more unstable, and that's going to lead to needing a surgery, which is no fun. I think y'all can see that there are vertebral arteries running along the side channels here of all the vertebrae. And so those poor arteries can get kinked off, they can get dissected, and they can get damaged if someone has a cervical spine injury. We're obviously not going to be able to see that damage if you get an x-ray, but if you have a severe cervical spine fracture, then you might be realizing, oh dear, those vertebral arteries or some of these nerves that pop out the sides of the vertebrae may also be compromised. And that will lead to the decision with your consultants about whether you need to get further imaging, like an MRI if you're worried about a nerve injury, or a CT arteriogram, like a CTA, looking at the vessels or the vasculature in the neck, if you're worried about an arterial injury. Realize too, there are tons of ligaments in the cervical spine, and these can get damaged as well. And this can be a problem because the ligaments hold everything in place. If you didn't have any ligaments, your cervical spine would just fall over, right? So the ligaments are actually really the strength element here. They're kind of the glue that holds the neck up and holds the neck in place. And so severe ligamentous injury can also be pretty damaging for particularly nerves, for the spinal cord, and for arterial vessels as well. And so any of these can be damaged, and realize you're not going to be able to see a ligamentous injury on a plain film x-ray. But if someone falls into that intermediate risk category with the PCARN, the likelihood that they have a severe ligamentous injury is pretty low because it's very hard to damage these ligaments. But if they fall into the high risk category, then you're getting a CT anyway, and you'll often be able to see ligamentous injuries or see kind of the evidence that they're there on a CT. But remember, if you really want to see soft tissue injury, then an MRI is the way that you're going to have to go. So let's talk a little bit about the cervical spinal cord. And I don't want to get into this in like terrible detail because it's super complicated. But just realize that the anterior part, so the part closest to the front of your spinal cord, is really responsible for movement, and so are the sides. And the back part is responsible for the sensation and stuff. So meaning this is the anterior part here, and that's where all the movement stuff happens. And this is the posterior part that's responsible for sensation. And you can get all kinds of different patterns of injury. Let me look at the chat real quick. It looks like you guys are having quite a discussion. Dr. Nick, do you want to summarize before I go through some of the cervical spine injuries to the spinal cord that we should worry about?
Hold on just a second. Saying hi to one more person. Yeah, so to recap way back. So while you're doing your recap, we actually had a bunch of people join. So we're going over the PCARN decision-making guideline to help you decide what kind of imaging is indicated for a lot of patients, whether you need a CT scan, an X-ray, or you can clear it clinically. One of the big things that we worry about is that we're over imaging because the ionizing radiation can be really dangerous. And I think to your point, that's one of those things that's easily overlooked, right? Especially in settings where you have access to the imaging. It's like, well, you know what? Fine, I'll just get it now, and it addresses your now problems. But we often forget just how high the incidence of cancer is in patients that get CT scans at a young age. I
Yep.
think the one suggested for a CT of the C spine that it increases chance of thyroid cancer lifetime risk by like 74%. Um,
78.
yeah, and
Almost.
and and that's why I think actually some places are starting to look at when they do a C-spine CT scan for kids, they'll stop at I think like C3 to avoid the thyroid, because a lot of the injuries are higher up. But then you also have to worry about Skilwara, which is cervical shoot spinal cord
Spinal cord
injury
injury
without
without radiographic abnormality.
exactly. Which is basically the spine's injured, but you don't see it on imaging. And that's one of the reasons that your exam is really important. It's really easy, I find, to go, oh, the imaging's negative, so I'm not worried about it. But we have to remember that everything has a sensitivity and a specificity and a predictive value, right? And everything's got a miss rate, right? Even if you have a super sensitive test, you still need somebody to interpret that test. Um, so something to keep in mind as well. Um, and then we talked a little bit about spinal cord anatomy. Um,
Yeah. Cool. That's a good summary for the folks who just joined. So, we did mention that there are bony injuries, ligamentous injuries, and blood vessel injuries that all can occur in the cervical spine. And so now we're going to move on to kind of spinal cord presentations. And we're not going to go into like crazy detail with these, but it's just for a heads up in case you see them. So anterior cord, we mentioned that the anterior part of your spinal cord is responsible for motor activity. So if you have isolated injury to this, then you are going to have loss of motor function below that point. And then you will maintain sensory function. Remember, if you transect the spinal cord, so like let's say that one of your vertebrae slides completely on top of another one because of an unstable cervical spine fracture, then you're going to lose motor and sensation. So these are all kind of partial cord injuries that can happen in the neck. Brown-Séquard is a really weird one where you can have opposite signs and symptoms. So you have motor loss on one side and sensory loss on the other because your sensory parts are in the back of the spinal cord, the posterior. So these columns right here. An anterior part of the cord is responsible for motor. You have a lot of crossing over of nerve fibers, and I'm not going to get into detail on that, but that's why you get changes on opposite sides of the body. The central cord syndrome is very uncommon in kids. It's something we usually see in elderly people, but I have seen it multiple times. And essentially, you end up getting sensory loss and sometimes motor deficits in the upper extremities more than the lower extremities. And so remember that sensory part, that's these columns here. And then the anterior part here is responsible for motor. And the further out we get from the center, the more distal. So like these are arms and then legs are innervated by this part here. And so you end up getting upper greater than lower sensory and motor loss for a central cord syndrome. Now, before PCARN, we had a wide variation in imaging, and I would love for people to chime in either in the chat or out loud as we go through the PCARN rule. Like, would you have pursued any imaging at all in those cases that we discussed? So, reminder that case one was unconscious patient, and we ended up getting a CT for her. Case two was a patient with kind of intermediate risk, so they had a GCS of 9. And we ended up getting an x-ray. And then for the last patient, they had a GCS of 15 and we didn't end up doing any imaging. They could be clinically cleared. And I'm going to type that in the chat. So feel free to chime in and say whether you would have done something different or the same. But the goal with the PCARN is to kind of standardize our imaging approach. And I realize that we're not always going to have the same things available to us. So imaging, I know, is limited in a lot of places. I've talked with a lot of the Makerere residents who have told me that sometimes it takes 2 to 3 days to get a CT scan, even for a patient who is in accident and emergency. It's definitely a lot different in my practice setting. So definitely chime in and say what things would have looked like in your setting for those patients we discussed. At this point, we're going to actually go through the PCARN study. And again, this really came out this year, so this is brand new. And PCARN is a huge network of US level 1 trauma centers, which means the biggest hospitals in the United States. And they've published tons of other stuff. They've looked at febrile infant, they've looked at head injuries, they've looked at belly pain, they've looked at so many things. And we'll go through the head injury rule next month. So the methods of enrollment for this study, it was a prospective observational cohort study, meaning that they're not doing any sort of intervention. They're watching what clinicians decide to do with people, and they're doing it starting at one point and moving forwards. So it's not looking at like old charts. It's looking at people who are now coming in from a certain point of time, looking forward. They included people who were 17 years or younger, so pediatric patients with known or suspected blunt trauma. And I know that age range can be a little controversial because by the time you're getting to 16 or 17, you're really almost an adult, but the cutoff between childhood and adulthood is kind of nebulous. So they looked at 18 different accident and emergency units in the United States that, again, were level 1 trauma centers. So this is where our most critical patients go. And all of the people they enrolled met one or more of these criteria. So they were evaluated by the trauma team, meaning a group of surgeons and emergency physicians. They were transported from the scene by emergency medical services, or they were transferred from another institution to be evaluated by the trauma team. And they ended up getting cervical spine imaging because they're trying to see who is actually sick versus not sick. So they want to know the people who did get imaging, we presume are sick. And they kind of looked at the data to see, was the imaging actually necessary? Like, what was the risk of a true cervical spine injury? And they excluded kids with only penetrating trauma. So we're talking like you got stabbed in the chest or you got shot in the neck, because that's going to be a lot different from someone who has a blunt trauma. In terms of what they considered to be high risk factors, and this was based on like prior studies and on data they had collected before. So more than a 10% risk of cervical spine injury was considered high risk. And the features that put people into the high risk category were having a very low Glasgow coma scale. So they're not really awake, or on the AVPU, which is alert, verbal, pain, unresponsive, the people were unresponsive. So very low awakeness. They had abnormal ABCs, airway, breathing, and circulation, or they had focal neurologic deficits. So like they had signs of those spinal cord trauma syndromes we discussed earlier. And then they did some really fancy math and statistics that I'm not going to get into because that is not my cup of tea, but they did what's called a classification and regression tree analysis to find who was at moderate risk of a cervical spine injury. So that's 2.8% risk up to that more than 10% risk. So if they fall into that middle zone, they're considered to be at moderate risk. And the things they found in their cohort that were moderate risk features were altered mental status. So maybe not the level of like GCS 3 to 8, but if you're in that 9 to 14 category, then you are altered. And then self-reported neck pain or tenderness on exam. And this one is pretty limited, just like with the Canadian cervical spine rules, or rather with the nexus criteria for adults. There's that sort of subjective portion to it. And I know Canadian also asked about midline tenderness. I think this is so hard in a grown-up because they're often, after an accident, people can be a bit hysterical and it's hard to get a real answer from them. And you're like, does it hurt in the middle or on the sides? And they can't tell because everything hurts. And think about that question is even more limited in a child, right? So they are going to say yes to everything. Kids say yes no matter what you ask them for most things. You can ask them, is the sky purple? And they might actually say yes to it. And so I don't know how much you can truly trust the neck tenderness on exam thing. But I think if the patient is altered and you push on their neck and they're grimacing, then that can be certainly a good indication. The self-reported neck pain, I would say, at least in my perception, that means the patient is informing you that they have neck pain. It's not, do you have neck pain? Yes, because kids are going to tell you yes to everything. So we're saying someone who spontaneously, when you say, where do you hurt? They tell you that their neck hurts. That's probably real, right? So be careful about that yes bias for kids. And then substantial head or torso injury is another one to think about. So if you've got horrific lacerations or contusions to your head, or you've got major contusions, fractures, positive FAST exam on your torso, then those people are going to obviously be at higher risk for a neck injury too because of the mechanism of injury. All right, so then results. They had almost 12,000 people in the derivation cohort, meaning like the people that they made the rule with, and then they applied the rule in another 10,573 patients. So this is like a huge study, right? They had like 22,000 people in this study. And one thing to note is they technically needed more people in their derivation cohort to make a very sensitive prediction rule. And so they did not meet the enrollment criteria that they pre-specified. So that's definitely a limitation to this study, despite the fact that it's still humongous. This is a large number of people. It was not as many as they had hoped to have. And then they made the 9-factor prediction rule that we went through in cases 1 through 3. And the sensitivity, when they applied it to the validation cohort, to those 10,500 kids, sensitivity was 94%, which is not bad. It's not perfect, but it's pretty darn good. And then the specificity was 60%, which is lower than I would like to see, but it's still fairly decent. And it can help us potentially spare some kids some high radiation imaging. Limitation here, obviously, is this was in high volume level 1 trauma centers in the United States. So the question is, can we apply this data to community hospitals, like to small places, even in the US? Can we apply this data in other settings where, for example, maybe kids are getting run over by bodas, which is not a thing that we see here very often? Or can we apply it in a place where people are having delayed presentations to care, which I know is common in all of your settings? So that's a really good question of, can you technically apply this rule in other places? And so this is a plug for those of you interested in research, especially those of you residents out there. We need somebody to actually look at rules like this, like the PCARN, and validate them in limited resource settings. So we need people to go out and do research and find out, does this rule actually apply where I live and work and practice? The other limitations here, they couldn't always get clinicians to fill out the surveys before they looked at the imaging results. So the goal was to have the clinician kind of blinded to imaging, especially if they were transferred from another hospital and had already had imaging done at the other place. But that's not always possible because this was a real world study, right? This wasn't a randomized control trial where you've got envelopes and people are blinded to all the steps and all the things. They tried to be as blinded as possible, but this is a prospective observational study. So this is looking at real world practice and what people actually do. And then the last limitation here is they didn't address who needs to get an MRI. They only looked at, do you do X-ray, CT, or nothing? And so the next step would be, who needs to actually get an MRI? Can anyone else think of other limitations of this study that we didn't mention? And you can feel free to put it in the chat or speak out loud. Anyone can feel free to speak up. Other limitations with the PCARN study. Dr. Nick, do you have any thoughts on additional limitations that we didn't go through?
Well, I really like your point on, how generalizable is the data, right? So I think that's one of the huge opportunities for research in Africa is a lot of times there's studies like this where it's at tons of massive level 1 trauma centers and heavily resourced settings where the conversation is, should we get a CT scan or an MRI, right? Which is not very generalizable. And so seeing how generalizable it is to other practice settings and or how comparable it is to what's currently practiced. So I think Deb said in the chat in St. Lucia, oftentimes family would decline CT scans due to the financial expense. And so they would stabilize the other injuries and then clinically clear the C-spine, maybe a day later or days later. What's the sensitivity and specificity for that? Right.
Right.
And what's the miss rate of CT scans, right? So I think those would be really interesting to see as well.
Yeah.
And then also who reads the imaging, I think is really big. Because my
Yeah.
sensitivity to read a C-spine X-ray is like 5%, right? Like, I'd have it
Yeah.
at this rate.
That's a great point, Nick. So, like we were discussing earlier before a lot of you joined us, that at a lot of our shops, like we are the ones reading the x-rays. And I almost never order cervical spine x-rays anymore because it's kind of the dichotomy of I'm not doing any imaging, or you're so sick that I need to get a scan of your head and neck most of the time. I don't see a lot of those intermediate category people, like the ones who fell into the 2.8% moderate risk group. And where I work only night shifts. And so nobody reads my x-rays at night except for me. And so if they fall into that moderate risk group, can I be trusted to read that x-ray? And then Nick brought up a great point. Like if you're doing delayed cervical spine clearance, what is the sensitivity and specificity of that? We don't really know. And I'm sure I'm not, I know actually almost everybody here works in a setting where the patient has to pay upfront for their imaging if they're going to get it. And so that's not the case where I work, but I know it's the case in Uganda and the Gambia. And so if you have to pay ahead, then a lot of people are going to say, heck no, I can't afford that. And then Nick also brought up what is the actual sensitivity of a CT scan for a kid. I know the data we have in adults shows that you really can clear the cervical spine with a CT scan. Like it's 99% sensitive, and it will even pick up if there's actual severe actionable ligamentous injuries. Like if you have a ligament that's ripped enough that you have an unstable cervical spine, a CT scan of the neck will capture that. But I'm not aware of any similar data in kids demonstrating whether it's truly good enough at looking at ligaments. And we know that the tissues are kind of more mushy, so to speak, in kids. So I don't actually know if a CT of the cervical spine is going to capture all actionable ligamentous injuries in a child. So those are all definitely limitations here. So let's quickly go over some guidelines. I did look in the Uganda clinical guidelines before this session. And it looks like this is all that they had for traumatic spinal injury. So people should be immobilized with a rigid cervical collar if you think that they have a traumatic spinal injury. And then they don't mention anything about the imaging that would be recommended depending on what the injury is. And then the Gambia actually didn't have any mention of traumatic disorders in the clinical guidelines. So for someone who's in the Gambia, maybe Muhammad or who else is here? Muhammad, I think you are maybe our token Gambian here today. Everybody else is from Uganda on the call. We would love to hear what traumatic disorder guidelines are you guys using in the Gambia? Is it kind of just clinical gestalt, meaning what is your gut instinct about what's going on with this patient? Or do you guys use the WHO trauma guidelines? Feel free to speak up or put it in the chat. So at this point, I'd love to open the floor to what do each of your institutions do? So had anyone already started using the PCARN rule, or what type of imaging would you be ordering for the cases that we discussed at the beginning? Maybe Sarah, Faith, Paul, Dixon, if any of you want to chime in. Agnes, Bernard.
While they're chiming in, like in the chat or unmuting, I think one of the other things you point out that you brought up that was really good is how generalizable it is from the mechanism perspective. So like I feel like we get a decent number of like they're playing football and they collided with another kid and now they say their neck hurts or their fingers feel tingly or something like that. And is it because you're 12 and hyperventilating? Whereas like if the mechanisms for who presents to the emergency department are very different, like as you mentioned, people are getting hit by vehicles as one of the more frequent presentations based on uh, patient selection differences, that might really impact how we navigate this clinically as well. Because one of the things I really
Yeah.
like to point out is like with guidelines, they are empowering, not replacing, right? So they empower you to make educated decisions and support your decision making, but they don't replace it. And so one of the things I think we really have to recognize is how generalizable is the study to like the patient that's in front of us. Because everything's got a misfit. And so like if you think, hey, this person might not fit this role for this reason, or yeah, this is generalizable with them, that could be really helpful as well.
Paul, I see you're unmuted.
Huh.
I'm curious if you have any thoughts. Does your institution have specific cervical spine imaging guidelines for kids? Bernard, I appreciate you replying in the chat. You said most of our patients come in from falls from trees and motorcycle accidents, which are much more severe mechanisms of trauma than Dr. Nick and I often see. And you basically always do the CT scan of the head and then extend to the cervical spine depending on the mechanism. So it sounds like you're using almost the same clinical gestalt that Dr. Nick and I were discussing earlier, but way more severe mechanisms of injury for sure. Um, so at this point, I think we'll kind of wrap up so that we're respectful of everybody's time because we're coming up on an hour. And I know there's another session going on right now that I advertised in the full CMES global announcements. It was on kind of like refugee experiences. I will send it again just so people have access to it. But so cervical spine injuries in kids are pretty rare based on the data we have, but can be severe and devastating. Younger kids are definitely at higher risk than older kids, and we need to make sure we do a full neurologic exam, checking strength, sensation, making sure that everything is equal. Consider using the PCARN rule. I would love to hear feedback from you guys later. Feel free to message me on WhatsApp and say, hey, I talked to my consultant at my institution and they said yes or no, we should be using this rule. So I would love to get feedback and close the loop on that. And then remember that imaging isn't perfect. So if you examine somebody and they have neurologic deficits, even if their imaging looks great, sclera is still a thing. And so I would still immobilize someone's cervical spine if they have hemiplegia, so they're weak on one side, or they can't feel you touching them. So err on the side of the C collar if they have true deficits that you are concerned about. Bernard, thanks for chiming in. The challenge is we don't have C-spine surgeons and it takes a long time to refer. So that's another huge component to consider. Obviously, like we should still get the imaging if we have it available to make, like if it's indicated. But then the next step, the next challenge is getting somebody to definitive care. Oh, I see this too. It takes a long time to get a report on the CT scan, and sometimes patients have to get reports outside the hospital. We have that issue as well. I know one of the sites where I work, sometimes it takes an entire day to get CT results back. This is like my critical access hospital, Nick, where I'll scan people overnight and sometimes the CT results don't come back until like the day shift. So it's very challenging to make decisions. And I'm seeing Bernard also saying we have to read them ourselves, which there's no studies out there to say how good or not good we are at reading cervical spine imaging for kids, as far as I'm aware. If someone does find a study on that, please send it to me because I would love to read it. These are my references, and I want to thank you guys so much for being here. And this is always a discussion that we can continue on WhatsApp, so feel free to message me. If you didn't already, please fill out the survey because this is how we make these sessions more relevant for you guys. And we try to pick topics that are interesting and applicable to numerous practice settings and learn about what everybody else is doing. It sounds like we're facing a lot of the same challenges with cervical spine injury imaging and things like that. And next month, we'll plan to cover the PCARN head injury rule because I think that's a really nice follow-up to the session today. Feel free to stay on if you have questions or chime in the chat. And otherwise, we'll see you guys next month. Thank you so much for being here.
Also, if there's something you have that's in like not in the survey, like but feedback or you don't want to use the survey or whatnot, feel free just to reach out to us. We'd love to keep refining this for you.
Yeah. Oh, actually, for those of you guys still here, I did want to let you know too, we are going to be having a women in medicine specific sort of journal club event starting in December. That's also run by CMES, since Techies Without Borders. We have a medical student who is super passionate about women in leadership in medicine, and she's recruited an awesome team of folks to help us with that. So keep your eyes out. There's going to be announcements in the global community chat for those women here, and a bunch of you are on this call today who might be interested in joining. So women in medicine sessions coming up. Yay. Cool. Thanks, guys. I see. Thanks, Bethel. Yay. Great to see all of you.